Welcome everyone to this episode of your Freedom Hub's Cash Market Free Patient. This is your host, Jeff Cantor, along with Charles Froman, and we're sponsored by the Marketplace for Health, Wealth, and Freedom, found at your-mp.com. And as usual, we are the disruptors intersection. We have a problem in the healthcare world. I think most people have figured out that there is one, and not everybody's put their finger on it. In truth, there's a few little guilty culprits in that middle slot there, not just only the insurance companies, but something's between us and the doctor, and that's where things came off the rails. And of course, the information's a mixed bag, so you don't really know what to follow up on or understand. And this thing gets funnier every week we show it because the news keeps changing and the realities behind these people keeps changing, so that's rather entertaining. And then just as a little sidebar, we do have another show we do earlier on the day, which is more about general freedom issues, definitely worth your while to check out. And again, you'll want to visit the program at our site, or if you're looking for some alternative for your health care, we definitely have a fix for that little cartoon we showed a minute ago available at this particular site. But let's zoom to the website a minute here just to do a quick tour. There's a lot to take a look at between the drop downs, but let's focus on a couple key ones. Under the home tab is both the webinar link and the continuing the conversation. Let's start with that one, because after you've had a great feed from the guest, you might want to follow up with that person. So when you click on continuing the conversation, here's your place where you can blog with them, donate, work on their cause, lobby, whatever sort of their issue and that you happen to match up with, and hopefully pick more than just a couple here because there's a ton of stuff to worry about. Dig into it. The other area in the same vein is this fighting for freedom area. When you click over there, it takes you to a lot of action issues, things to get your name on and help push forward, as well as being aware of other organizations that are out there that you might not really even know exist. So it's a nice thing to find out about. But if you come back to home and you go to the webinar button, that's where we are for right now. And so when you scroll down, you'll see a breakout on the guests of the day, the early slot and the one for today, now 7 o'clock. A rundown on who's coming up so you can plan your calendar forward, and we'll talk about that. And then very importantly, here are the links that take you to where the video is archived after we record it today. So let's say as an example, you go to this Brighteon tab, and here you'll see the history of the ones we've been doing. This has been going on for years, so you'll see there's a lot of great ones to look at. And again, if you like any of these, you can then continue in the conversation with any of these people. So that's the whole idea behind it, is to kind of make some things happen, not just take a nice warm shower, feel good, and then just go back to everyday routine. Why don't we get up off the couch, and here's how you do it. So on that note, though, let's see what we're going to be working on today. So Charles, why don't you take the role of introduction here?
Gladly, Jeff, and welcome, Mark. This is a favorite topic of mine, integrated care, because just as Forbes featured the disruptive plan Jeff and I sell for making cash patients by cutting their insurance costs in half, by replacing insurance with sharing and empowering them with tax advantage health savings accounts to take control of their health care. We like how these cash patients think for themselves to save money, and that inevitably leads them to alternatives for what their doctor recommends. And that kind of push and pull with doctors is what is needed to fix this healthcare market. But anyone testing their ideas in this space quickly finds there's a lot of aggressive conflict and competition between standards, allopathic care, and integrated or even natural care. And that happens with most markets. There's competition between the status quo and the entrepreneurs, but patients want all of the above. And whether it's Mark Testa or Ruth Lindinger or other friends of ours, Jeff, we know that long-term, in addition to empowering patients as cash shoppers, they want to have better providers and doctors that have better integrated knowledge or just easier access to a continuum of care among these different specialists where the natural is included. And what's interesting is Dr. Testa has bridged that gap. He's been a chiropractor in a hospital. He knows how to speak to regular doctors and how to get them working together. And that, of course, is extremely important as insurers and insurance companies try to find some second opinion or quality filter way to stop the overutilization of surgeries. Now, a lot of surgeries are necessary, but there has to be a lot more give and take there. And that is one specific area where Mark has really found his niche with Regenexx and other ideas how to help folks avoid surgery and work on chronic issues, which is another big issue. Half the country is chronically ill and they're in pain, and a lot of those stem from musculoskeletal problems. So we're going to solve a lot of problems tonight, Jeff. And how do we integrate integrated care into health benefits? How do we get natural and allopathic doctors more integrated, cooperating, and dealing with the chronic care epidemic? So that's our intro there, Jeff.
Okay, great. Well, I'm ready to find out how Mark has become such a great ringmaster there, and we're going to give him control of the screen to demonstrate that.
All righty. Yeah, well, thank you, gentlemen. Charles, you picked up on it. We met a few, months ago, earlier in the year, and you really latched on to my experience as an integrative care provider, and so I'm glad that you picked up on that so quickly. I think it's where we need to go, and so I've got 25. It's hard to put more than that because it makes me old, but I got even more than that years of experience in integrative musculoskeletal care. And so I'll share my background on this and sort of the path I've been on. And chiropractors are entrepreneurs because we've been out of the system. We were never part of the system. And I graduated in Southern California in 1990, pre-internet, no money, no one knew me. And I was like, where am I going to get patients? How am I going to do this thing? I mean, I was really scared. So that got me thinking. And so let's talk about that for a minute. So I asked the question, where are all the patients? Where are they? Well, they're in primary care. They're with the MDs. I'm like, how do I get there? How am I going to get them to come to me? Physicians still looked at chiropractors back then as quacks. And when I was in school, I think it was maybe 87, 88, the chiropractic profession finally won this long, drawn-out battle against the AMA, where they had an all-out assault on the profession to squash us, right? They made it so that their members couldn't refer to us. They weren't even allowed to interact with us. American College of Hospitals, American College of Radiology, all of them followed suit, and they all fell after this lawsuit and showed that this was a design to ruin the profession and really hold a monopoly on healthcare. And even before, years before, physicians thought they had realm of everything, including dentistry. So this was a big, challenge. And, literally when I got out of school, man, people still called me a quack. And I had no idea. I grew up in Ohio going to chiropractors. It was part of our healthcare system back then. In our family, we were first generation Italians born in America, using our bodies to make a living, not going to the doctor, but going to the chiropractor. I thought everybody had access to this. Little did I know. So how did I go from the swap meet to the hospital? Literally, my first gig in Southern California was in a large chiropractic practice. And like I said, no internet, no money, no one knew me. I went to the Orange County swap meet every weekend for a year. And I there were 100,000 people that went through there. I talked to people and I got new patients out of there. And I hated it. But that's how I built my practice. And that's when I started asking, where are the patients? And I've realized, again, with the physicians. And so I started my foray into building relationships with doctors. And two things I noticed right away. You got to go to the back of the line. You got to take their failures. My way in was, hey, give me your failures and I will take care of them. And they want to know, what do you mean? Your spinal failures, your joint failures, the surgery failures, the myofascial pain failures. I'll take all your failures. And I went to the back of the line because in healthcare, you can't get in front of the money. And what that means is I could not take money out of the specialist's hands or the primary care provider's hands in lieu of them seeing me. I mean, at the end of the day, everyone wants to feed their family. And if they referred to me too soon and I got people better, they weren't happy with that. So, and I noticed that in a pain practice where I was at, where they did injections. And sometimes patients would come to me right away and they never saw the injection guy and they were not happy. So I had to take failures, go to the back of the line. Today, I'm in a hospital system 5 days a week and I'm at the front of the line because we have an integrated care model. We are all paid fair on a salary. Nobody gets more money for doing more procedures. And the integrative care model works really, really well that way. We all share the clinic. We all share the same EMR, EHR. I sit next to the providers. We talk about patients. And so in this model, primary care is at the center of it. It's at the center of it. And it needs to be a fairly savvy musculoskeletal based providers. And I'm in a work comp clinic. So a lot of what we see is musculoskeletal. So they have to be pretty savvy on that. The other really cool thing about, at least here in Colorado, is a lot of what we do are guideline driven. And I know people don't like guidelines, but I look at guidelines as just a roadmap, right? You can take different routes. We got guardrails up, but we're not going to get out of control here. And in Colorado, particularly, the Colorado work comp guidelines are evidence and community based. So I've been on the guideline committees here before, and you all are in the room, all the specialists, the surgeons, the pain guys, the psych, the behavioral health, the PT, the podiatrist, and sometimes we got to hash it out. Like, and so maybe there's not a lot of evidence that acupuncture helps hip and low back or hip and lower extremity pain. That was the guideline I happen to be on. But the community as a whole realized that it was yet beneficial. And I really did. I had to duke it out with a pain doc who tried to put acupuncture into a different realm, saying, well, you need to make sure they're eating well and getting good sleep and exercising. I'm like, who does that? No other provider makes sure their patients are eating well, getting good sleep, are meditating. So don't isolate out a procedure that actually can help, basing it on some weird standards. And so we really did kind of duke it out. And at the end of the day, the guidelines were allowed to stay in with acupuncture, because I also do acupuncture. And in my prime, I was probably doing 1,000 needles a week on patients for musculoskeletal pain. So I spent the majority of my career in primary care, bringing up the rear of musculoskeletal care with one of the largest primary care groups. I think they are the largest here in Colorado, with one of the largest functional medicine primary care groups at the time in Boulder. And we saw so many conditions that were misdiagnosed, kind of brushed away. It's all in your head. And, when you start really peeling the onion apart, you can find a cause for people's conditions. I spent 8 years in the largest physical medicine and rehab pain practice here in Colorado. So we saw a lot of surgery failures. We saw a lot of failed back surgeries. We saw a lot of joint replacement issues. We saw a lot of people who didn't really do well with traditional care. And there's a lot of that out there. There is no one good solution for any of this. I spent time, a couple years with a spine surgeon and shared a lot of cases with him, literally in his office. And then in occupational medicine, I was the first guy to bring some procedures to ambulatory surgery centers here in Colorado in the late 90s, early 2000s, with an old osteopathic treatment called manipulation under anesthesia. And for selected, really well selected patients, we did well with them. And I followed those patients using outcome data for a year, and many of them did quite well after that kind of procedure. And then last stop is here at Denver Health. It's the safety net hospital, but they have multiple outpatient clinics. And, you know, it's been a privilege for me to really sit with specialists and providers and share our knowledge and get different points of view. And that's what you get, right? I have a different point of view than the surgeon. But when we talk, we meet very commonly in the same place. And so that was another thing I learned. Like, if I'm going to integrate, I got to walk like a duck. I got to quack like a duck. I got to act like them. I wore the lab coat. I sent initial and final reports. I remember one physiatrist I worked with introduced me to a colleague. She's like, he actually puts treatment plans together with goals. Like, that's what they do. So the best way to integrate is to all kind of be on the same page. So right now we have PT and massage therapy that I work with. I bring up the chiro and acupuncture. The primary care provider controls all the referrals, right? He or she gets everyone's notes. They know what's going on. They control meds. They control imaging. And here in Colorado with the work comp guidelines, unless you have bladder or bowel disturbance or maybe lower extremity numbness or tingling or weakness, 6 weeks is what the guidelines say before imaging, because we can take 100 people off the street with no back pain, and 80% of them will have a disc bulge or a disc issue or a pinched nerve or something, but no symptoms. But you send that to a specialist who, when they have a hammer in their hand, everything looks like a nail, and they see that, they're going to do a procedure. And so the primary care throttles all of that and really controls it. And I keep saying she because I work with women, but she will control when they go to the specialist and when behavioral health gets ordered, which is not enough. I can tell you that is the one key that we do not use enough. It is used, but certainly behavioral issues play such a role in musculoskeletal pain and such a role in recovery. And I've had the opportunity to work with some great psychologists in behavioral health. And I recall one patient, she was a cutter. She had about 11 different surgeries. Nothing ever really helped her. I saw her one time and she was a cutter and had a lot of cuts. And I went to him and I said, hey, I'm not going to help her. He's like, you're not going to help her. This is what he said. Give her your best placebo and let her move on to the next thing. And that was such a wake-up call for me because I'd never really dealt with that sort of stuff. So that's where working together as a team improves diagnosis, improves points of view, improves treatment algorithms. With the PT now that I work with, as soon as I evaluate a patient, because she's usually seen them, I go over to her. I don't tell her my diagnosis. I ask her, what do you think? And we communicate, right? Or I'll go to the specialist, the primary care doc actually that I work with, and she'll ask me, what do you think? And I'll tell her. And so we can catch people symptom magnifying, we can catch shenanigans, we can catch all kinds of things. It's funny, I've always told them, I did go to Catholic school, I was an altar boy, but when patients lay face down on my table, they confess to me just about everything. And I had one patient tell me, yeah, the pain doc gave me 30 opiates, 30 supply of narcotics. I don't have that kind of pain. I sold those. And I'm like, don't tell me that kind of stuff, because right now I'm going to go tell your doctor, and we're going to have to probably cut you off of the drugs. So, that stuff happens real quick and in real time, and that is such a value. It removes silos, it allows communication, it improves care, it improves diagnosis, because in musculoskeletal medicine, about 20% of the diagnosis is wrong. And in one study I saw out of Mayo Clinic, when they see patients as a center of excellence, 88% of the time the diagnosis is revised. So, and we've seen too many patients get surgeries that didn't help, and you wonder about the diagnosis. So that's sort of the integrative model that I have really been involved in, and the quality, here's another great example. I was in primary care. I saw a patient for right elbow pain. He was a cancer survivor, lung cancer, heavy smoker, and was treated and was never quit smoking. And so he came in to see me, and I treat him and he'd get a little better, but he'd be like, man, this pain at night, it's so bad at night. It's so bad at night. And I took that to the primary care doc. I'm like, I think he's got a what's called a Pancoast tumor, a tumor in the lung right up here, compressing his, I'm going to let someone in here. Or maybe you can, Jeff. And so I said, I think he's got a tumor because his pain is so bad at night and I'm not really helping him. Sure enough, he had a Pancoast tumor up here compressing the veins going, or the nerves going down his arm, and he was dead in 6 weeks. So, I mean, we couldn't help him, but that collaboration was quick. And that's another really great thing to integrative care. Back to guidelines real quick. So the Colorado Work Comp guidelines have been adopted by national, ACOM, American College of Occupational and Environmental Medicine, nationally. They've been adopted by a half a dozen or more states. You go to ARC, which is another research-based outcome guidelines. I mean, in the American College of Internal Medicine put out guidelines on just about everything. Hardly anyone follows guidelines. And that's part of the problem with healthcare as well. Everybody's got the next best answer. You ask every doctor, 99% of their patients get better. It's all fee for service. That drives utilization because I got to make a living. I got a Mercedes, I got a second house, I got a boat, I got a divorce. I mean, these are real things that I saw. I got a gambling debt. I got a $700,000 tax bill. These are real stories that I saw in practice that drove over utilization. And so, fee for service is a bit of a problem itself. Now that's the ugly. What's the ugly side of integrative medicine? Not doing it, right? It's hard to pull off. And I was just in a meeting today with a high value chiropractic acupuncture PT network, a high value value-based surgery group, Regenexx, which I'll talk about in a few minutes, and insurance brokers. And they couldn't figure out how to utilize this because they still rent the BUCA network, and the network has really restrictive guidelines for carve-outs. So we got a great solution. It's going to save you money. We know the front door they walk into will determine the cost and the outcome. So if they go to chiropractor or PT first, they're going to do better in cost and outcome. And it's really difficult to get this thing utilized. That's the other part of the ugly system is the BUCAs have, even if you are self-funded, made it so difficult if you're renting their network to put in good value-based care. I mentioned fee for service, business as usual it's hard to change the practice of medicine. There's a stat that it takes 17 years to take some innovation from, the bench to the practice. It takes that long to get innovation happening, and that's ridiculous. And then you got the doctor buffet. The doctor buffet is, here's my insurance card, go to any network provider you want to out there. There's no transparency on cost or value, and you can end up, with the guy with the 2 car payments, the divorce, the $700,000 tax bill, the gambling debt, and I've seen it, and get overutilized care and no better for it. So that is the ugly part of this. It's hard to integrate. The bad part is, again, transparency. Few physicians keep outcomes. We at Regenexx, with what we do, we follow the outcomes over 35,000 patients and are totally transparent with that. Very few people will go at risk. Some do. Direct primary care, value-based physicians, will do that. ACO models of primary care will go at risk and take 80% of the revenue based on outcomes. Then they get paid additionally if it works, if their services work. There's a lack of good quality networks, right? So the scenario, the meeting I was in today, we got the chiropractic PT acupuncture network, we got the surgery network, we got a Regenexx clinic here in Colorado, but we don't have it across the United States. So we can implement it in one of 50 states. And then really those providers are largely in the metro area. And so there's some driving required. Other problems, are the primary care providers really know the ecosystem best as to who are the value-based providers. And so in the integrative model I'm in, when I started there, I walked in and I said, never use these guys, never, ever refer to these guys, because I knew them. And the primary care docs know them, and they know who's good and who's not. And so we have a very narrow network of spine surgeons, orthopedic surgeons, pain docs, other chiros if I can't see them, very narrow network of massage therapists, very narrow network of behavioral health. But that's a problem too, because if your little ecosystem are the only ones that know who are good, it's hard to get good integrative care. People don't like narrow networks. They want the buffet, right? Nobody wants to be on a diet, especially in America. So that's another issue, is the behavior of consumers. And we're not even consumers, we're sheep in healthcare here. And if the doctor says go here, that's where we go. Why do we go? Why does that doctor say go there? Because they're golf buddies. That's it. Or because that guy gives me a lot of referrals. He might not even be good, but I get a lot of referrals from him. And so a lot of this drives the value of, and the quality, not even the value, but the quality and outcomes of healthcare. This is the bad part of not having an integrative care type network. There's a lack of compliance with randomized controlled trials and guidelines. I mentioned some of the guidelines. They're great. They're quality. And yes, you can go outside of the guidelines if you have a good reason why. In Colorado, they just built in PRP, platelet-rich plasma, which is finally an accepted treatment here because it can avoid steroid use, it can avoid surgeries, and yet it's not utilized enough. Randomized controlled trials. Let's talk about that for a second. There's been 3 of them on knee meniscus surgeries, 3 randomized controlled trials published in New England Journal of Medicine, some of them in the 2 in the US, 1 in, I believe, Finland. Look, it's no better than physical therapy or sham surgery. And it's the most common elective orthopedic surgery in the United States, 700,000 a year. And when they remove that little bit of meniscus, the joint collapses and now you're on your way to a knee replacement. Guaranteed. That's what happens. Even before the research was hitting like this in the 90s, when I'd see somebody that had meniscus surgeries in the 80s, because they used to just remove the whole thing. You'd look at their knee and be like, I realized this right away. Like, as soon as you open up a joint and start messing with it, it deteriorates, it degenerates really, really quickly. And so yet surgeons are doing 700,000 of these a year. Maybe they know it leads to a joint replacement. We had one device company come talk to us at Regenexx for some device related stuff, and they called it the joint train, because you start with the meniscus, you get the partial joint replacement, you get the total knee replacement. It keeps everyone happy. The hospitals are happy, the surgeons are happy, anesthesia's happy. It's the patient's not happy. So, I mean, there's a term for some of this stuff. And then I mentioned this already, the lagging improvements in treatment advancement. 17 years. Finally, PRP made it into the work comp guidelines. Surgeons have been using it to repair surgical incisions, especially cardiothoracic surgeons when they crack the chest open. Dentistry has been using it for a long time. And so it just took forever to make it into musculoskeletal medicine. Again, because there are, special interests everywhere you look for this. And we were even approached by a large insurance company that said they wanted to try bone marrow concentrate, which is where stem cells live, for musculoskeletal conditions. We put together a pilot project with them, just one or two indications. And I went to them and I said, why do you want to save money? Why? I don't even believe you really want to. Tell me why you want to do it. Because when you spend more, that medical loss ratio, that 15% profit you're allowed to keep, grows. Every time you spend more and you raise premiums, it grows. Why? Why would you want to do this? Oh, we want to. We're the innovation department. Guess what? That rug got pulled out immediately. As soon as they took it to their policy people, it was a done deal. The medical loss ratio, the profit, the special interest, kind of keep business as usual. Now, the good thing is, there is good to this whole thing, is multiple perspectives. As I mentioned, right? We can actually look at the body differently. I look at it differently. I never had drugs and surgery as a tool. So I have to look at things differently. What other tools work? Is nutrition viable option for reducing inflammatory conditions in the body? Yes. Do I recommend turmeric and fish oil for musculoskeletal pain? Yes. Do I recommend topical capsaicin, hot pepper cream for certain conditions? Yes. Does the surgeon? No. Does the guy who's injecting steroids? No. They don't even know about it. So this is where those multiple perspectives come in. And once you start doing this in an integrative model, the primary care docs are grateful to have some other opportunities. The surgeons, really, the ones we work with, the narrow network, they're grateful because not everyone's a surgical candidate to them. So once we start sharing this and realizing nobody's dying from taking fish oil, I'm not killing anyone with turmeric. People start to embrace it, especially when patients come back and say, this is making a difference in my life. And when people tell me that, I always tell them, when you go to your doctor, make sure you tell them this because they need to hear it from you. I'll put it in the notes, they'll read it, but they need to hear it from you. This really provides holistic care. And, probably in the 80s and 90s, we started specializing. Doctors started specializing. Primary care kind of fell out of favor because specialists could make 4, 5, 10 times more money than a primary care doctor. And so they learned more and more about less and less. And they forgot that, the head bone is connected to the knee bone, we're all connected. It's all connected. We're interconnected. Our brain, our spirituality, our nutrition, our sleep, our community, right? We're seeing it now with social determinants of health being more of a driver of bad health than what we actually, more of a driver of bad health and impact, the ability to impact people more than what we do to people. So only about 20% of what we do really impacts people's health because these other drivers affect it more. So when you have this holistic point of view, and especially if we can get behavioral health pulled in, patients really start to make improvements. And they just want to be leveled with. Many of them just want other tools. Many of them don't want to take pills. Most people don't want to have surgery. But if you're not getting that point of view from people like me or massage therapists or acupuncturists, they never get exposed to it. And I can't tell you how many patients told me, why didn't they send me to you first? And that's where you can't get in front of the money comes in. But so many people asked me that question because they're like, they did the shots, I did the steroids, I did the burning of the nerve. I've been adjusted 3 times and it's the best I've felt since the injury. Integrative care throttles the use. I mentioned 6 weeks before we order imaging. Nobody goes to a specialist right away. Sometimes in the system I work in, they use the ouch line, the nurse case manager, the nurse line, and they'll start there. Yeah, go home, rest, take some ibuprofen, put some ice on it, let us know in the morning how you're feeling. Sometimes that stops the whole process, right? Or care coordination. And I sort of think of integrative care as a care coordinator. employers pay a lot of money to specialists who coordinate the care for them. It's hard to get utilization. You got to really incentivize it, but the primary care provider is the best care coordinator. They see everyone's notes. They know who to work with. They throttle the use of aggressive treatments. They throttle the use of drugs. Like in our clinic, nobody gets opiates. Nobody. The only people that prescribe opiates are the primary care doctors. I'm sorry, the specialists. And so, and in Colorado, we have the PDMP, the physician drug sort of dispensing registry that all pharmacies use now as well. All pharmacies, all physicians utilize the PDMP. And so we can look up if other people are prescribing opiates to patients. The pharmacy knows who's prescribing opiates to patients. If they see it coming from multiple points, we're able to jump on it right away. That's another key part of integrative care, the pharmacist, frequently overlooked. I think the primary care provider does a great job of managing appropriate expectations. And sometimes that's not done really well with specialists. They don't spend a lot of time with people. They hold up an X-ray or an MRI and say, I can get you in on Tuesday. Yeah, you definitely need surgery. 99% of my patients get better, which is BS because they're not really tracking outcomes. Nobody does. And so the primary care provider manages expectations. I manage expectations. I level with patients as well because they ask me, should I get the steroid shot? They know I don't do them. I have no skin in the game. And I tell them, look, man, you could get 2 hours to 2 weeks of relief. That's what I've seen. And did your doctor tell you, one, steroids can cause avascular necrosis of the bones. Bone will die. Did they tell you that? No. Did they tell you that steroids kill stem cells and tissue within the joint? They didn't tell you that. Did they tell you that it will affect your diabetes adversely? No, they didn't tell you. Did they tell you for a woman it'll mess up your menstrual cycle for a couple months? Did they tell you that? No. Did they tell you that they will suppress your immune system? No. That's what I do. I help manage those expectations and share the reality because I've seen all that in my practice. And you know, I got no skin in the game. I want people to avoid that if possible, but if they don't, then they're fully informed. I think the other good part of primary care, especially innovative primary care, are, you know, they know what the new tools are in the toolbox. So they're looking out for new things. And digital PT, I mean, we're seeing it all over. Just like the growth of telemedicine, we're seeing digital and telemedicine physical therapy where you can do it at home or at your workplace growing and making an impact. At least that's what the data is starting to show. So we'll continue to follow that as it you know, gets more mature. Digital mental health. There's a lot of that available now and covered by insurance. Just like telemedicine, it's digital. And so hopefully there's becoming less of a stigma to this and primary care providers are recommending it. I know I recommend it to people, these things, and I share it with them and suggest it. And it's still got a stigma. And yet it is probably one of the biggest game changers when you can develop some mindfulness-based techniques. You can learn how to meditate. You can learn how to breathe. You can do a body scan. I mean, mindfulness-based stress reduction out of I forget the university. They've been researching this for years. John Kabat-Zinn. It's great. It's part of the PTSD treatment now. We're also seeing new technology, or not even technology, but new things coming out with depression with psilocybin or MDMA or other things. I mean, that I hope makes it past FDA because the data that I'm looking at is the research on these when done in a controlled environment with a guide, with a therapist, followed by talk therapy, outperforming, you know, Prozac and Paxil. And for longer periods of time of good outcomes. And then lastly, some of these providers, I mentioned PRP, the orthobiologics. And I want to just kind of touch on that because orthobiologics have the ability to reduce the need for up to 70% of elective orthopedic surgeries. I hope in my life I get to see that happen because there are still too many orthopedic surgeries. You do not go to sleep, get the filter changed, and wake up all good. It just does not work that way. And the downstream effects are ubiquitous, and people don't ask enough hard questions about that. So what are orthobiologics? And I'm going to use, this is what I know. So this is what I'm going to share, Regenexx. So we've got all these conservative care treatments here. And when they stopped working, and this includes drugs, people had to leap across this chasm to surgery. And like, I remember the surgeons were like, she's not a good surgical candidate, but we don't have any other options. And so people would have misused or overused surgeries. Now we've got a needle-based procedure where we can inject your blood platelets or your bone marrow concentrate, which have stem cells and other cells in them that can stimulate repair of damaged musculoskeletal tissue. It really can reduce the need of up to 70% of elective orthopedic surgeries, and it's a fraction of the cost. It's not surgery, it's needle-based, it's your cells, minimal rehab, minimal pain, minimal opioids, minimal missed time work. So innovative self-funded employers get this, and they are adding this to their benefit plan. And when we share our outcome data with them, because we track the outcomes of as many of these patients who are willing to be part of the registry, I mentioned 34,000 patients, we can show a 70% reduction in pain, a 50% improvement in function, a 70% overall improvement, self-reported. We track who ends up going on to surgery. We know when it fails. And so when we share our data, it's totally transparent. And so employers have been able to do this. Needle-based repair, or help facilitate the repair of bone, ligament, cartilage, tendon, muscle, all needle-based. And if you remember open heart surgeries, you don't see that. Like in the 90s when I got out of school, we saw a ton of that, the cabbage procedures. It's not that around anymore like that because they got interventional cardiology. This is the next evolution of orthopedics, is interventional orthopedics using the needle to replace the knife, which obviously is a lot lower risk as well. So integrative care, we've got to build these networks. We've got to get transparency. We've got to get good primary care involved with it, whether that's direct primary care, but they are the quarterback of this. It's really got to be value-based. Some people need to go at risk with this, and we've got to adopt new technology to make it happen, and it's very possible to do. So thank you for your time and attention. Here's where I can be reached. I'm glad to take any questions or comments, and thank you for the opportunity.
Absolutely. And we'll definitely open up for some questions. I would start off with one. When you were describing the operation that you're at, where you have like a narrow network, as it were, so you kind of make sure you're referring into the right people back and forth. Do you guys own the whole operation, or is it owned by like a hospital where they're going to be more in charge? Or is that the secret to you having that ability?
Now, where I see patients as a chiropractor,
just when you're describing that idea of that integrative model, because, I know like here I'm in Cleveland, so they got the Cleveland Clinic, the doctor's owned by the clinic. So anything they recommend is a test at the clinic. They never recommend them outside of the circle.
Right. Yes. So at Denver Health, the only things we have in-house that we utilize is me and PT. We don't even use our own MRI machine. We do not always use our own surgeons, although I like our surgeons because they're paid a salary, and so they're there to do the right thing. But we don't always use them. We do use the community as well. So we don't hog all the money. We don't keep it all to ourselves. Again, it's about finding the right providers.
Sure. And the reason I was prompted to ask the question because it was my own thought, but we had somebody in the audience asking them to see if Kathy, maybe you want to unmute yourself and kind of add your aspect of the question, because she's got some personal tie-ins. Are you able to? Well, while we let her get on mute. Oh, there
Okay,
she is.
I'm
There you are.
unmuted now.
Okay,
Hi,
good.
Kathy.
Hi. Yeah, just, having worked for Dr. Delcor for a while and just having come from a place where a hospital, which is a rural hospital that is connected to a large healthcare system known as Intermountain Healthcare. I mean, a lot of times they have actually given bigger discounts in terms of a cost to um, insurance or third party people who do not use Dr. Delcor's surgery center. It's just like part of their contract. So that's kind of swampy. And it seems to have nothing to do with quality because Dr. Delcor's quality is actually higher than their employed orthopedic surgeons. So I'm just wondering, do you consider when you send people out into the community what the costs are and the quality and all that?
So that's a great question. In the system I'm there's a fee schedule. So it's not, you're not going to get more than the fee schedule allows. And so, again, I'm in a work comp system, in an integrative model. So we do know the quality of the surgeons that we work with, not because they're keeping outcome data, but because the patients come back to primary care and they know whether they did, got a good outcome or not. And, a few bad outcomes or a few bad reports back from the doctor will start to influence the referral patterns. But the costs are baked into the Colorado work comp fee schedule, which is very reasonably priced. So nobody's gouging, nobody can overbill. And so it's kind of a controlled ecosystem.
Charles, I see your hand up.
Yeah, I got a couple questions. Great presentation, Mark. Exactly what I think the system needs, that integrated care led by Cairo. In fact, that's what Dr. Jack Wolfson recommends, the paleo cardiologist. He wanted everyone to start their primary care with a chiropractor. And I think even in the socialized system that some of us don't like in Canada, I think they do utilize chiropractic care as primary care more so to get quality and to save money. So first about standards, can standards be privately created by professionals in sort of a certification body type of aspects as opposed to the government?
Are you talking about guidelines?
Yeah, tell me about that, because I've heard from a lot of experts that have said bad things about the standards of care. It leads to pressure on maverick doctors from medical boards. What do you know about all that dynamic?
So yeah, that's a great question. I think the guidelines that I've looked at, ARC, I can't pull up my notes, ARQH, it's a national guidelines database. There's also multiple guideline databases. The Colorado Work Comp Guidelines is evidence and community-based. So when we get into a room, it's all the providers. It's the women and men who are treating the patients. And then there's Dr. Ed Whitney, who brings us all the research. I don't know where he finds it, but he's the master in public health here for the division. And we look at research, and then we really duke it out, literally duke it out. What's right, what's wrong, what should be in, what should be out, what does the evidence show, what does the community say? And it's not the government, it's the community that is doing that. There's a lot of chiropractic guidelines. Again, evidence and community-based. The boards of medicine, different boards, they've tried to put their own guidelines together. So if you go to the ARC, I'm sorry, it's in my notes. Let me get out of the screen share here and I'll pull that up. So yeah, you do not, am I screen sharing still? No.
No, but my
Okay.
question is not so much against guidelines that professionals create for their own professions to guide their behavior,
Yeah.
but more the weaponization of it to go to target maverick providers that don't use the guidelines that maybe patients may like, but may not be what the majority of the professionals like. Do you see the difference? One is professionals making guidelines to guide their profession. The other is creating a trap where the maverick providers may not want to be limited by the guidelines, and maybe the patients also may not be want to be limited by the guidelines, but they can't because they're outside the guidelines.
Yeah, right. Then, I've seen enough maverick providers. I've done a million chart reviews in my day, and they're maverick and they need to be controlled. They're doing the wrong thing. They're harming people. And so I've weaponized guidelines. I'll be the first to say I've done that, because in some instances they need to be. In other instances, though, and if there's a third party oversight, I've keep going, keep doing it. You're doing the right thing. I know you're beyond what the guidelines say, but it's working, and keep doing it. So, if someone's doing oversight, they got to really be true and just and have their own internal compass to apply the pressure in the right places, because sometimes it needs to be applied. Other times, a good doctor, if he's the maverick and he can fight for his patient, like the work comp guidelines here, you can go outside of the guidelines. All you got to do is present a good case. Why do you need to do something different? Just tell us. We're open to hear it.
It's good they have that flexibility. Where Charles is kind of coming from is, when it's just completely consumed by government, as it were, then they suddenly get, pay to play people involved, and the doctors that soft that ranch, boy, they're out of the hospital system or banned. So yeah, that's the concern. And like what you described, you're looking for that one person, but the angel we used to have that made those decisions got replaced by this other hardline person, and now the whole thing's horrible. So it's risk. It's a very, and like you said, there are doctors. We had a doctor that we're buddies with, and you've probably seen this. I'll tell you a story you've heard before. He reported one of his fellow compatriots because they were sending in like a bogus photograph every so many to Medicare, and he was getting paid on it. So they finally said, well, how many do you think he's doing? They said, he guesstimated the amount. They said, oh, that's too little. We can't go after a guy that small. He's just going to get away with it. So yeah, it's always fraught with all this waste. And again,
it is.
It's taking money from your pocket as a doctor where you deserve it. You're the one doing the work. And the patient's paying too much for, like you said, to be overutilized, churned, to use a term, they're churning them like they're the stockbroker, type of thing, just buying and selling stock a day long to make commission. So it's a shame. Charles has got to follow up here.
Charles, your point, like when we would try to get MRI approvals and they'd say no, that is over egregious use of guidelines. And I would argue with people. I'm like, you're not treating them. My first question to those doctors is like, when was the last time you had your hands on a patient? When was the last time you actually took care of people? Because you're just sitting there looking at a piece of paper and making decisions, and you got your head somewhere where the sun don't shine. I would be the first to go after those people. I agree with you. That over egregious use of guidelines is BS, especially when people are doing it who don't treat patients, haven't treated patients, are washed up, are retired, have failed in practice, and that's what they go do, and they can get paid by an insurance company or a government agency to say no and rubber stamp it. You got to have people like me and other providers, and I've heard our primary care docs go beat the hell out of those people, and you got to stand up to them.
We're reaching that point for sure. I see Charles had a little follow-up there.
Yeah. Go ahead.
Yeah, we'll explore that later. For my health client, National Health Federation, June 18th, I'm going to host a Zoom with a variety of experts on what to do with the FDA and CDC, because Milton Friedman said the FDA kills people by keeping life-saving drugs out of the market and harasses natural competitors to pharma. And the CDC is just completely captured by pharma and has led this hysteria over the past year. But how we reform those two agencies is really up in the air. Some folks want to privatize, some folks want to use private certification bodies. Other folks want to give natural entrepreneurs more speech rights to advertise the healing properties of their therapies, where they're now limited to just structure function claims. There's a lot of different experts who argue over the best method. Some folks want to replace licensing with certification boards and limiting inspections to how well you comply with the criteria of the certification body. Anyways, thank you for your perspective, because it's kind of a new area. There'll be a lot of experts to weigh in, but the politicization of the standards versus the standards themselves is kind of what I'm interested in finding out more about, because there's good and bad examples of regimes and how they work. You don't want to have over standardization of care. You want to have that incentive to continually innovate, like you're doing with Regenexx, for example. Are there some governmental limits to your pioneering area in Regenexx? I mean, whenever you have new areas, you're going to gore some ox and piss off some special interest.
That's a great one. So yeah, of course, FDA has an issue with stem cell culturing. They say that's creating a new drug. And so that's not allowed in the United States. We do not do that in the United States. They've been very clear about using bone marrow concentrate in musculoskeletal conditions, and that seems to be of no concern to FDA as long as it's used with in a homologous way, meaning that bone marrow concentrate turns into ligament, cartilage, bone, and tendon, and that's the body's use of it. They're also great and clear again with clarifying that it needs to be autologous, meaning it comes from you and goes back into you. It can't be someone else's. And they're also clear on more, meaning you cannot more than minimally manipulate it. And what we do is just concentrate it. And that is considered that is not more than minimal manipulation. That's where stem cell culturing comes in, and they consider that a new drug. So we've been compliant with FDA guidelines along the way, but not to say we haven't had some run-ins with FDA on stem cell culturing.
Yeah, we have a friend, Jeff and I, in Tijuana, because cash patients can do medical tourism, and those with money often do seek care outside the country that is cutting edge and effective, but for whatever reason hasn't gotten FDA's approval yet, which puts some American entrepreneurs like yourself at a disadvantage. Because I think there is a lot of upside to what you're doing. Wouldn't you say that FDA is kind of unnecessarily hampering a bit?
They're not hampering us. I think we're hampered more by the insurance industry, right? This is they're either your cells, they're going back into you. There's no drug there. There's no billion-dollar payout at the end of the day. It doesn't bode well for hospitals and ASCs because it can be done in a doctor's office. There's a lot of reasons that hamper the advancement beyond FDA. And so in our case, it's not necessarily an FDA issue. It's more of an insurance issue. And then all the players that are tied into all of that, there's no upside. To do a clinical trial on, your own stem cells for one indication, say knee osteoarthritis, to get FDA approval would cost $200 million or more. And a couple years, well, they're your cells. There's no big payoff for that. There's no drug company payoff. So that sort of research probably won't be done for a long time, if ever. And that's the only way to get FDA approval for an indication that say your stem cells can be cultured and used for knee osteoarthritis, structure function claim. And that's just you're not going to probably see that happen, not for a long time. So that's a little hampered that way.
There's a perfect place where we have to enter that. What do you know? Money's involved.
And one follow-up, Jeff, if I might.
Sure. Okay, real quick.
Real world example. So for the 3 bunionectomies I've gotten, because I guess my, the metatarsal from the ankle to the big toe is blocking the big toe phalange from bending up, so I can't push off the balls of my feet to do my athletics. So the podiatrist or orthopedist puts me under, digs around in there, clears it out, and it helps one foot. The other foot, it doesn't help. Would your injections nowadays, is that the new novel treatment middle path that may have proven a better decision all those years ago when I got these failed bunionectomies?
Yeah, it may have been a good solution, and it still might be a good solution if you have pain. You know, the other thing too, again, with a holistic point of view, is look up the chain. What is going on with the spinal nerves? Is there something going on with the nerves that are affecting the function of the muscles that are altering the gait? You know, you got to kind of start putting it all together. And when you come to a Regenexx provider, that's what they're going to look at. Okay, it hurts down there, it's messed up down there, it's only effective on one side. What's going on with the nerves, the symmetry, the movement, the all of that, and then address it all? Because so many people, you know, get procedures, but sometimes their problems higher up, like in the spine. So it's still a viable option that you could get more mileage out of your body that way and maybe address more of a root cause. No guarantees, but.
That was a great way. Now it's even a better way to end the day, Mark. We just fixed Charles.
All
So,
right.
so there you go.
And that's what integrated care can bring you, right?
That's right, right there.
Right.
We made sausage today together. All right. Well, thanks, Mark. That was great. Thanks, Dr. Testa, for today.
Thank you for inviting me. I appreciate it. Love to share the info.